Welcome back to Tube Talk, everyone. This is Brian Miller, your Associate System Medical Director, here with episode number 3, and it's about staying midline. In our last episode, we focused on the 50-50 view and how crucial it is to our success. In this episode, we're going to take a few steps back and talk about the placement of the blade, walking down that tongue, and eventually ending up in that vallecula in a midline fashion. We've had a chance to review a lot more of your video laryngoscopy recordings, and I'm pleased to see that the key elements for intubation success are continually being performed more and more each day. However, we still have a lot of room for intubation improvement, and this is one of the areas that we want to focus on and take a deep dive into now. And so, without further ado, let's jump right into episode number 3. Before we get into everything, I want to review with everyone the 5 tips for intubation success again. That's obtaining a 50-50 view every single time, deliberately curving our bougie, always staying midline, suctioning before and as needed during our intubation, and then for bougie hang-up, performing the ring's right maneuver, and then for tube hang-up, performing the inlet left maneuver. For those that are really closely watching, you may have seen I skipped over point number 2 in our video series. That's because I'm combining that with number 5 in episode number 5, covering all things bougie. So let's move right into tip number 3 now. Staying midline from blade insertion down to the vallecula is a very important part of our intubation technique. If we get off the midline early, we may get lost in the soft tissues around the tongue. A little bit deeper, we may lose tongue control and displace it accidentally off to the left or the right, which can cause problems. At the level of the vallecula, if we're off the midline there, we may not get the trap door effect on the epiglottis to expose the cords well. So we need to be meticulous in staying midline as we're working our way down, identifying our landmarks, and eventually setting up our 50-50 view. Let's take a look at a video for a good example of how all this works. Here we are, scissor blade suction, blade at the tip of the tongue in the midline. We have the suction clearing the path of the blade here as it should. We have the uvula down there in the middle, hidden by a little bit of secretions. We're slowly and progressively working down the middle of the tongue to identify that epiglottis. There's the epiglottis now. We place the blade directly into the midline of the vallecula. We see our glottis is now just generally in the middle of our screen. We're not seeing or favoring one sidewall of the back of the throat or another. And we're also, looks like in a 50-50 view, maybe a little bit too much cords there. Could have come back just a little bit, but this is looking like a totally doable airway for us to get at this point. There's the bougie coming in right now. Looks like we're having a little bit of initial difficulty passing that bougie. Could have maybe curved it just a little bit more or come back on our view just a little bit. But looks like the bougie now is passing very well. Passes after a return to the back and we get hold up on that bougie. I'm going to pause this video for just a second as there's a little bit of tube delay. And here comes the tube now. Looks like we don't have any hang up and the tube goes right below cords nicely. The intubator now maintains their blade in the position to withdraw the bougie, and looks like bougie comes out right there. And the last thing this blade sees is a perfectly good tube. When we're talking about staying midline all the way down, we're also hand in hand talking about the concept of progressive epiglottoscopy. This is the concept that we're not looking for cords. We're working our way progressively down to identify our landmarks in the epiglottis, which should be a static structure directly in the midline, and we should be able to find that, and we know what comes after that. You may find it helpful to think in your head or even say out loud the process. Scissor, blade, suction. Or if it's grossly contaminated, scissor, suction, blade. We're going to place our blade at the tip of the tongue, start doing short walks down the tongue. We may identify the uvula, although that's not a prerequisite to moving on. And then we find the epiglottis. Once we find the epiglottis, we're going to place our blade into the vallecula, and that should expose the cords. Throughout all of this, we want to stay as midline as possible so we set ourselves up for success to find each of these structures and move forward. When we start off with, we want to do our scissor technique, place our blade at the tip of the tongue directly in the midline. This is going to set ourselves up for success. However, occasionally we may not be able to do this traditional midline insertion oriented with the chin. This can occur when the camera and the handle of the blade bump into and are physically restricted by a patient's large chest wall or mechanical CPR device. This can make it challenging to even advance the laryngoscope into the oropharynx initially. We can overcome this, though, by inserting the laryngoscope obliquely. If we think of the chin as a 12 o'clock position, we can orient the laryngoscope towards the 10 o'clock position, or around 30 to 60 degrees to the left. Once the blade is advanced into the oropharynx a bit, There should be then sufficient room to rotate back to the 12 o'clock position and to continue advancing our blade. Once we have rotated back though, we need to focus on staying midline. While the oblique technique is great if you are encountering an obstruction to your initial blade insertion, I would not use it routinely on all of your intubations as it has a higher risk of shifting you off the midline. I want to briefly get nerdy with everyone and share a journal article from the Annals of Emergency Medicine, which was published in June of 2021 of this year. It was entitled Engagement of the Median Glossoepiglottic Fold. Wow, that's a mouthful. Let's just call that fold right there in the middle of the vallecula and laryngeal view during emergency department intubation. It featured two authors, Brian Driver and Richard Levitan, who are some of the preeminent emergency medicine researchers for airways. Dr. Levitan has taught thousands of people to intubate, aka these guys really know their stuff. So what did they do? They looked at about 180 intubation videos and saw did the intubator engage that fold or not, and then measured the view that they got after they engaged where they were. So what did they find? They saw that engaging the midline vallecular fold with the blade tip was associated with an improved laryngeal view. They did use a standard geometry blade, which is a little bit different than our UE scope, more hyperangulated blade, but I believe the principles still apply here. And so our takeaways from this, if you hit that midline vallecular fold, you get an improved laryngeal view, which is almost always associated with a higher chance of you being successful on that intubation. I want to share a few images from that journal article as I think they very clearly demonstrate what we were talking about here. In this case, the blade is at the base of the tongue and is about to be placed into the vallecula. You can see it's a nice setup. The blade is already in the midline there, and we don't see too many soft tissues at the back of the throat on the left or the right, and we're not hugging one wall or the other. The white arrow there demonstrates that midline vallecular fold. That is the target of our blade. We're going to then place the blade into that fold directly in the midline. That is what we want to do. If we're off to the left or we're off to the right, that is out of position and we're not in the midline and we're not going to get that trapdoor effect or the lift of the glottis upwards what we need. So we want to avoid being off to that left or the right and stay straight in the middle. When we realize that we're out of position at the vallecular level, we need to do two things. First, we need to place our blade tip back into that midline vallecular fold. And second of all, we need to check our angle of entry of our blade at the level of the mouth. In this case, you can see that our blade is far off to the left and we're essentially sweeping over the tongue and hitting cross-angled at that vallecula. We need to bring that blade back into the midline and then place it into that midline vallecular fold. Let's take a look at a video of how being off midline causes lots of complications. The events of this video happen very quickly. There's no progressive epiglottoscopy and there's no suction leading the blade. The blade is immediately placed at the base of the tongue. We see the uvula right there, and then the epiglottis suction comes in briefly to clear the path. However, we place the blade actually in a midline fashion to start with. However, then the blade is accidentally shifted off to the left side, and we are clearly to the left of that midline vallecular fold and off center on this airway now. And we actually maintain this now. You can see that the left wall of the back of the throat is more prominent, and we're kind of hugging it there. And we also see some fluids pooling back up. This would have been a great airway for salad. However, our blade is off on that left side, which would make salad very difficult. You see the bougie is coming in as immediately having difficulty, and we accidentally shift our blade back a little bit, and we're certainly not in the vallecula right now. That goes back a little bit right there. You can also see secretions building up more and more because there's no salad technique on this airway, and the bougie is continuing to have trouble. You can also see that we're intermittently losing our view now with CPR, and that's all because we're not in the vallecula right there. So the bougie continues to have trouble, and ultimately this is an unsuccessful airway due to not being in the midline. Another key aspect to our intubation technique is tongue control. This is particularly important in those patients with a larger tongue that fills the mouth and makes our blade insertion more difficult. It's also important for those pediatric patients as they have a larger tongue relative to an adult. As we start placing our blade at the tip of the tongue and start working our way down midline into the tongue, it's important to maintain some gentle pressure to trap that tongue on the floor of the mouth as we walk down. So essentially, we release that pressure and walk down a little bit and then maintain that pressure again. Release that pressure and walk down and maintain that pressure again. Continuing to do that progressive epiglottoscopy while controlling the tongue. If we start sliding off, we can often end up in the corner of the soft tissues there. This often raises our heart rate as we start to not be able to identify our landmarks as we're working our way down. And so we need to correct that and get back to the midline. Sometimes that may be going right back to the tip of the tongue and starting our walk down again. If we get off to the side, oftentimes that burns time up and we spend a lot of time over there as we're confused. So we want to correct that immediately and start getting back into that midline and start walking down. An additional tip for maintaining tongue control and staying midline is being purposeful on where our eyes are looking at the beginning of our intubation. When we insert our blade or really any instrument into the mouth, we should do that under direct visualization. That means instead of looking at the camera screen when we are navigating around the teeth and the tongue, we should be watching directly with our eyes the blade being inserted and our suctioning so that we can more easily see what we are doing in these early steps. Once we can't see the blade tip anymore, that is when we then shift our view to the camera screen. Let's look at a video where we didn't have good tongue control or directly observe the blade being inserted. This looks like a patient with a very large tongue consuming a lot of the workspace of the mouth, and the blade is positioned on the far right side initially. Here comes suction coming in, and we're just generally lost in the soft tissues of the side of the throat there. We're actually so far right that we see the patient's molar there, and we're maintaining no tongue control whatsoever. And at this point, we're actually just staring at the tongue tissue itself and really just lost and not sure where to go here. And so looks like we pull back out, come in from the corner of the mouth, not in the midline like we should be, and we still have no control over this tongue and are generally lost. Now we're at the bottom of the throat, dabbing the blade there. That's a great way to contaminate your blade. And finally, after about 50 seconds, we get our first view of the cords and the glottis. We're a little too deep because we didn't do a progressive epiglotoscopy, and now we come back out and we actually place the blade into the vallecula and get a generally 50-50 view. Not bad after all the issues that we had at the beginning of it. Here's the bougie coming in, and the bougie passes down, and looks like we go down to hold up at about 25 centimeters, and now we're just waiting on the tube to come in. And here comes the tube. Looks like the tube passes nicely. However, the blade comes out before we pull the bougie. This is about a 90-second intubation, and overall our biggest issue was tongue control and walking down that tongue in a midline fashion. If you're having difficulty controlling the tongue on a patient, one tip is to use suction to facilitate your blade insertion. Some anesthesiologists actually use a tongue depressor to trap the tongue against the floor of the mouth and facilitate their blade being inserted. You can use your suction device to trap that tongue in a very similar fashion and also displace the mandible open a little bit to give you some room for your blade to be inserted. This is one method you can use. However, if you have a grossly contaminated airway, you probably still need to use suction to lead your blade down, as that takes priority at that point. Another area to focus on for tongue control is to avoid performing a tongue sweep to the left. That's left over from our direct laryngoscopy days where we were sweeping off the tongue to the left so we could see the cords in an unobstructed fashion. However, with a VL scope, we have a camera at the end to show us all that we need to see. We actually want the blade maximally engaged on that tongue to control it, and we don't just want to displace it off to the left side. Let's take a look at a video to see this a little bit further. Alright, so the blade's inserted a little bit off the midline initially, as we can see a molar right there. We're not really watching with our eyes down at the mouth, initially inserting our blade and controlling that tongue. We're trying to use our screen and just getting lost for a second. Finally pulling back and seeing the tongue, and now we're kind of like in the mass of the tongue off to the right side. And we do see suction, and it seems to be leading the blade, which is good. However, now we're essentially just loading this tongue on that left side, and you see the entire mass of the tongue. We can actually see the uvula down there at the bottom left of your screen, and we're completely off to the right now, and we see the tongue completely swept off to the left. And so we also see a bunch of right-sided soft tissue structures at the back of the throat, nothing on the left. We're doing a decent little incrementalization of the blade walking down, but we're certainly still short of the vallecula here. Choking up a little bit more. We're using suction meticulously, which is great. However, we're still on that right side, still not into the vallecula there. And we finally start getting a little bit further down into the vallecula. However, we don't get the trapdoor effect as we are off the midline on the right at this point. Still aren't seeing cords. We go over to the left here to try that. Still not on the midline. Go back to the right side again, and we still haven't seen cords at any point. And all of this is not going very well at this point. We pull out. All of this intubation's difficulties were essentially because we tongue swept to the left at the beginning and ended up on the right side. Very similar to avoiding a tongue sweep to the left is that we also want to avoid displacing the tongue to the right with our blade. This is actually more common than we think, as we do a lot of work with our suction on the right side of the mouth, which tends to make us favor the left side of the mouth when inserting the blade. We need to be careful with this. And so as you can see in this top right photo, the entire mass of the tongue has been displaced off to the right side there. Here's the tongue superimposed to give you a better idea of what we're talking about. Now when we look in that bottom photo, that tongue has actually displaced our bougie posteriorly or down towards the esophagus. And this actually makes it more difficult to actually get that bougie to lift up and go into those cords there. So this is the main danger of displacing our tongue off to the right side, is we actually end up with bougie issues as well. Our last video of the day is a DAA intubation with ketamine, where the tongue is displaced off to the right side. Let's get started. We see the blade is placed at the tip of the tongue and starts working down in a midline fashion. However, then at the last minute, we fall off the tongue and it displaces off to that right side. Now we're being shoved down the left side of the airway by the tongue, and we end up in the left side of the vallecula right there. Generally, we have a 50-50 view. However, this is not going to be favorable, as that tongue has now been shoved off all to that right side and is causing issues with the bougie. We see the bougie is going posterior and we're having difficulty controlling that bougie. Also, right here you can see the midline vallecular fold has been dragged off to that right side as that tongue has been displaced off to the right. So at this point, we continue to have issues with the bougie throughout this airway over and over and over again, and we can never actually pass that bougie despite getting very, very close multiple times. There you can see the tongue at the right side just a little bit more, and I'm going to end this video now as this intubation was ultimately unsuccessful. Well, that finishes up episode number 3 of Tube Talk, everybody. I hope you learned some new knowledge from it, and we'll bring episode number 4 to you very shortly. As always, if you have any questions, please reach out to myself or any other member of the OMD. In the meantime, take care and be safe, everybody.